Lecture 10. Indication for cesarean section. This lecture will focus on the indications for cesarean sections. Cesarean section is one of the most important obstetrical surgeries. It can be a life-saving procedure, but it is major surgery and must only be performed when medically indicated. In this lecture we will explore maternal and fetal indications for cesarean section based on evidence-based medical guidelines. This lecture will focus on the definition of a C-section, the indications as well as maternal and fetal considerations. A C-section is a surgical procedure to deliver a baby through incisions in the abdomen and uterus. It is one of the most important obstetrics interventions and is key for ensuring safe childbirth. Access to C-section in sub-Saharan Africa is limited, especially among rural dwellers. However, global C-section rates have increased from 12.1% of births globally in the year 2000 to 21.1% in 2015. This increase is in part because of increasing maternal age and more complex maternal medical conditions. Within Africa, approximately 3% of all births in Western and Central Africa are C-section versus 4.6% in Eastern and Southern Africa. This is less than the WHO recommended 10 to 15% C-section rate. The 10 to 15% rate has been shown to be the rate that is required to reduce maternal and perinatal mortality. Comparatively, the C-section rate in Tanzania is approximately 6%. Maternal indications for C-section include significant health issues like gestational hypertension, preeclampsia, and eclampsia. A history of previous cesarean sections or uterine surgeries such as a prior myomectomy also necessitates careful consideration for C-section. Anatomical obstructions, such as large fibroids or vaginal septa, may obstruct delivery. Fetal indications for C-section include evidence of fetal compromise. This can be diagnosed with auscultation of the fetal heart rate or electronic fetal monitoring. Fetal heart rate monitoring does have limitations and must be interpreted by a skilled healthcare provider. Other fetal indications for C-section include malpresentation such as breech or transverse lie and severe congenital anomalies. These factors require immediate assessment to ensure the safety of the fetus. Other fetal indication includes umbilical cord prolapse, which requires an emergency C-section. Poor fetal growth and certain infections like untreated HIV or active herpes simplex virus also warrant surgical intervention. Some other reasons for C-section affect both maternal and fetal health. Some examples include abnormal placentation, such as placenta previa and placenta accreta, which can lead to severe complications. Placental abruption and labor dystocia are also significant factors influencing the decision for a C-section. Cephalopelvic disproportion can lead to labor dystocia where labor is no longer progressing in either the first or second stage of labor. Over the next few slides, we will discuss in more detail some specific considerations for C-section. Breech presentation requires careful evaluation. Not all breech types are suitable for vaginal delivery. For instance, footling breech and larger breech babies cannot be delivered vaginal in most cases. A low threshold for C-section is advisable in these cases. Women with a history of a previous cesarean delivery may consider a trial of labor after cesarean section. This is also called a TOLAC. We previously referred to this as a VBAC or vaginal birth after C-section. Given that a vaginal birth is not guaranteed after a C-section, a new term was introduced called a TOLAC or trial of labor after a C-section. If the TOLAC is successful, then you can say someone has had a successful VBAC or a successful vaginal birth after a C-section. TOLAC is associated with a risk of uterine rupture of the prior C-section scar. The risk of uterine rupture is about 0.5% if someone has had only one prior C-section. However, you must carefully consider who is a candidate for a TOLAC, as not everyone is safe for a TOLAC. TOLAC is generally indicated for women with a singleton pregnancy in the cephalic presentation who had a prior low transverse cesarean section. Any other form of uterine incision, such as a midline uterine incision, is likely a reason to consider a repeat C-section. Counseling is essential to discuss the risks and benefits of attempting a TOLAC versus repeat cesarean. There are certain circumstances where a TOLAC is absolutely contraindicated. These include a prior classical C-section, a prior T or low vertical uterine incision, a history of a prior uterine rupture, or prior major reconstructive surgery on their uterus, such as a full-thickness myomectomy. Other considerations for a repeat cesarean section include 2 prior C-sections or less than 18 months between the prior delivery date and the likely current delivery date. Clinicians must evaluate each case individually to ensure maternal and fetal safety. Ultimately, the necessity of a cesarean section must be clearly established. Misconceptions about C-sections being a safer alternative to a vaginal delivery can lead to unnecessary surgeries. Informed decision-making is essential in obstetric care. Cesarean sections carry risks including surgical complications such as heavy bleeding, infection, and injury to surrounding organs like the bladder and bowels. They can also be associated with increased postpartum health issues such as surgical site infections. Awareness of these risks is vital for both healthcare providers and patients when considering delivery methods. To optimize outcomes, healthcare providers should consider TOLAC in appropriate candidates, implement active management of labor which includes appropriate fetal monitoring to ensure timely interventions when necessary. One must also consider the techniques used to perform a C-section. Various surgical techniques and incisions are used to reduce complications, such as surgical adhesions and uterine rupture. Clinicians should be aware of both immediate and long-term complications associated with C-sections. The timing of a cesarean delivery can significantly impact fetal outcomes. Elective C-sections should be scheduled at 39 weeks or later, unless there are clear maternal or fetal indications for earlier delivery. Preterm deliveries require additional considerations to optimize neonatal outcomes. Women who have undergone a cesarean section face unique considerations in future pregnancies. Risks such as placenta accreta spectrum and uterine rupture should be discussed. Appropriate time between pregnancies and counseling on future delivery options are essential for optimizing outcomes in subsequent pregnancies.